So good afternoon, good evening, all of you. So I would thank first AstraZeneca for arranging such a wonderful meeting of precision oncology in lung cancer. So we all aware that lung cancer is one of the best example of any solid tumor where the precision oncology has really helped our patient in improving their outcome. So definitely it has set example for means other tumors where we expect that we should have such target therapies available so that further outcome of other solid tumors can also be improved. So my job here is today to share such example of lung cancer patient where how precision medicine has helped my patient to improve their long-term outcome. Next slide. I'm sure that this my case is so interesting that it will definitely set up a stage for our panel discussion where we can definitely discuss further issues here. So my case, I will start with the case. So my patient presented with history of, actually he's a 46-year-old gentleman with no comorbidities, no addiction. He was EGFR PS1 at the time of presentation. Next slide. So he presented to me in September 2018 with a chief complaint of backache and hip pain for 2-month duration. Then he had a history of change in voice since 15 days. And he had one episode of seizure just a day before he came to us. Next slide. So he was investigated at our center. We did a PET CT, which showed a primary neoplastic lung mass with bone, lymph node, lung, and pleural metastasis. He had a history of seizures. So we did a MRI brain, which showed multiple brain metastasis. So we did a lung biopsy, which was suggestive adenocarcinoma. So it was 2018. That time we did only EGFR cross. So his EGFR exon 19 deletion was positive. Alcan ROS was negative. PDL1 was less than 1%. So our final diagnosis was stage 4 lung adenocarcinoma, EGFR exon 19 deletion positive. Next slide. So this data we all are aware what are the options for EGFR positive lung cancer patient metastatic. So we can use either first generation EGFR TKI. So nowadays we rarely use it alone. We generally combine with other therapies nowadays. That is gefitinib or erlotinib. We have second generation EGFR TKI, that is afatinib, dacomitinib, and we have now third generation osimertinib also in first line, which is now a standard of care. Even we have combination of erlotinib, ramucirumab, erlotinib, bevacizumab, and even EGFR TKI plus chemotherapy data from TMHP we have, and we are routinely using this all of these agents. Next slide. So at that time we started this patient on first line osimertinib. He had very good response to osimertinib initially. He almost had a regression of most of his lesion. He did, but he did well only for 10 months actually. So he actually not had a long response on osimertinib, and only after 10 months he progressed. Next slide. So we always discuss in various meetings what should be done after osimertinib. So there is definitely no clear-cut answer to that. Most of the clinicians use only chemotherapy. So even in FLORA trial, we can see here in out of 279 patients received osimertinib, almost 133 patients received second line therapy. Out of that, most of the patients received only chemotherapy. So some people say that ABCP, that is the atezolizumab, paclitaxel, carboplatin, is the best regimen to be offered to this patient post progression osimertinib. But very few people can afford that. Is a very costly regimen. So we generally end up giving only PEM carbo, which is the routine chemotherapy. So even if you see this data of comparator arm, that is EGFR TKI, here out of 277 patients, 180 patients received second line therapy, and out of that only 47% of the patients received osimertinib. So that means that if the patient don't get osimertinib in the first line, there is a very less chance that they will get second line osimertinib. And the patient has received chemotherapy osimertinib in the first line, most of the patient received only chemotherapy. Next slide. So my patient also received PEM carbo as a second line chemotherapy. He responded well to PEM carbo, and then he received maintenance pemetrexed, and actually did very well on maintenance pemetrexed for almost 2 years. He received almost 29 cycles of maintenance pemetrexed. After that, he developed new onset liver metastasis, that is progressive disease. Next slide. So when he progressed on PEM carbo, I thought his disease biology is really very good. So he actually not responded to PEM osimertinib. which was expected to have DFS of around, or PFS of around 20 months. He progressed in only 10 months there, but he responded very well to PEM carbo. So I thought, let's do NGS again and just see what is happening here. So I did a biopsy from the liver lesion this time, and that was a new lesion, and I did NGS this time. So actually, initial progression was around in 2019. That time, NGS we were not doing that routinely, but this time it was 2021 May. So we did a NGS here. So surprisingly, what I found, there was a EML ALK4 fusion here, mutation fusion positive along with the mutation in EP100 gene. So I tried to find out what is happening here. I tried to find out some literature here. Is there any data for EML ALK4 fusion as a mechanism of resistance to osimertinib, or any data on this after progression on osimertinib? So next slide. So I found a good, interesting case report from our Indian hospital only, that is Rajiv Gandhi Cancer Institute by Dr. Ullas Batra. So he has reported one case of EML ALK4 fusion as a resistant mechanism to osimertinib, and he treated this patient with osimertinib and alectinib combination. So basically, what happened here is that in this case report, what he have reported that his patient, when progressed on osimertinib first line, repeat NGS was showing EML ALK4 fusion along with original EGFR mutation positive. So what was different in my patient was that there was no EGFR mutation positive, but only EML ALK4 fusion. So what I did, next slide. So I thought it may be because of tumor heterogeneity. So that's why what I did, I started him on alectinib in May 2021, but I did a liquid biopsy also to find out whether there is a EGFR fusion, EGFR mutation still present in one of the clone, which is not picked up in biopsy, but maybe picked up in liquid biopsy. So interestingly, I got the EGFR mutation exon 90 deletion positive liquid biopsy, which was present in the baseline biopsy. So I did a lot of discussion here. I presented in our actually molecular tumor board also. So what we decided to add actually EGFR TKI also. So that time the patient was saying he will not afford osimertinib because alectinib was already costly for him. So we added gefitinib. Next slide. So after this combination of gefitinib plus alectinib combination, response CT scan at 3 months was suggested a partial response. And after 6 months, he had a very good ongoing response to therapy and is also symptomatically much better. So clearly, this clearly shows that sequential biopsies may definitely open a potential strategy for new novel treatments. And definitely NGS and precision oncology can help us to further improve the outcome of the patient, which may be definitely not written in any clinical guidelines or any book, but definitely we can always get a new mutation, something different post progression on any targeted therapies, and that can definitely open a way for next line targeted therapies. And definitely, so as the data is evolving for osimertinib resistance or any means like aceritinib resistance or lorlatinib resistance, we can definitely explore this data on resistance mechanism, and depending upon the whatever the resistance patient has developed, we can start the next line targeted therapy, which can even further improve the long-term outcome of this patient. So I will end here. Thank you.
Thank you so much, sir. So any questions or any comments from the team for, you can unmute yourself and ask questions or any comment from your side, from the audience.
So I think we can move forward and we can discuss in our panel discussion also.
This panel, okay, sir. Sure, no problem.